Good morning once again, everyone. So now it's my great pleasure to introduce the next speaker to this audience. So, a very eminent nephrologist, Dr. Dilip Rangarajan, who is the Group Medical Director and Senior Consultant Nephrologist at NU Hospitals, Bengaluru. So, he has completed his MBBS and MD from the Madras Medical College. You could see that he topped the entrance examination for the entrance into this post-graduation program. And since then, I think he specializes in nephrology. And he is currently the Group Medical Director at NU Hospitals in Bengaluru. And he is running a DNV nephrology program as well at NU Hospitals. So his topic today, he will be covering on the digitally enabled healthcare and use of robots in surgery, which is, I think, very, very relevant. I mean, as we move towards, the society 5.0. So increasingly, a lot of sectors, I mean, especially healthcare, is going to be impacted not only by AI and ML, but a lot of robotic advances as well. So it's a great pleasure to have you here today, sir. I really welcome you to take over the stage and address our audience. Thank you very much. Let's welcome with a round of applause.
Before we hear the speech, as a token of our love and appreciation, may I now request Sri Ratnakar Rao to honor our resource person, Dr. Dilip Rangarajan, with a shawl and mountain. Thank you, sir.
Good morning, everyone, and thank you, sir, for a good introduction. I bring you greetings from NU Hospital, which is a standalone nephrology center in Bangalore. We have branches at Bangalore, 2 branches in Bangalore, one at Shimoga and one at Ambur in Tamil Nadu. We also run the Nephrology Center at Maldives, the government Maldives hospital there, Indira Gandhi Hospital in Maldives. Now, we had a fantastic teacher in cardiology during the student days. He was KP Mishra, who's a cardiologist, was working at Apollo, basically it's Odisha. He had a typical Orient accent. So he used to teach us ECGs in a common forum. So there's something called abnormal beats called ventricular ectopics, which will stand out like a sore thumb. He used to stand out like a sore thumb. So it looks like as if I am standing out as a sore thumb among a group of engineers and engineering one. But I justify why I am here. I'll show you that we are also digitizing a lot in our hospitals and for delivering healthcare. So I will not be really a sore thumb, but probably relative sore thumb compared to the engineers who are on stage here. Yeah, I want to speak to you on digital health and use of robotics in medicine and surgery. Now, digital health has really, I would say, revolutionized healthcare. There are a lot of things which we didn't assume and presume earlier that we could do, we're able to do now with a lot of digitization. And the comfort that you have in this handling this digital thing is something to be seen to be believed. There's brought in a lot of safety, especially a lot of safety devices. I'll show you some what we're using in our hospital. a lot of safety factors for the patient as well as for data, which is very, very important in a hospital setting. Connectivity that this stage has brought in is something remarkable. I'll show you the telemedicine how we are well connected now compared to where we were some years back. Now, examples of digital health are the Arogya app, which became very popular during the 2 years of raising COVID. And the proposed ABDM, the Ayushman Bharat Digital Mission of the Prime Minister, where the digital health of every citizen is going to be integrated into a common electronic record. So let us say today I go to Apollo Hospital for something, and tomorrow I go to some other hospital. The entire record of yours is digitized, and it is transmissible from one hospital to another. So the other hospital need not go through the entire history. All your history will be digitized, and you will have it will be very, very easy for you. The patient also need not carry heavy records from one hospital to another, because the first one contains all the data about it. You just have to update the new next hospital about the newer development and not the previous one. So this is in process, and very shortly there are some training sessions which are going on, how to use them for the doctor's point of view, from hospital point of view, etc. Once it introduces, it really revolutionize healthcare, because the data will be available for everyone. Of course, privacy will be there, but the data can be easily shared across hospitals rather than wasting time going through the records all over again. If you are a doctor, you will know that a new appointment patient comes, they come and throw a set of 10 files on the table. Start from 1998 onwards till 2022. It's very difficult to, and it's all not in orderly fashion. 2021 will be in front, and 1999 will be next, then will be 2010, then will be 2012. So by the time you arrange and see all these things, half an hour will go off for this arranging this. So we have employed some physician assistants to put all this in order from the date onwards, so that we can easily go through patient record. So all these things will be made easy if this new one is implemented, because all data will be available for everyone at the tap of a button. Now, I'm not going to talk about bigger things like what you had, like AI and big data and all, which are being increasingly implemented in the healthcare sector. I will talk about common things where we have used technology in healthcare in our hospital, which has made the life simpler and safer also for patients. Telemedicine, let us go through the list and then I'll deal with it one by one. Then electronic records, that is online case sheets of the OPD cases. Digital images, and summary dictation, that is either your discharge summary or death summary or any referral doctor's summary to be dictated, or any letter that the patient wants. Patient safety devices is very, very important. Our IT sector and of course our HR. Now coming to telemedicine, in fact, everyone including me was very, very reluctant to use telemedicine till a couple of years back. Because one, it doesn't give you the connect with the patient directly. Two is that you cannot examine the patient and get the physical features from that. You can only see someone, the image, when you cannot examine, get a lot of data. Like for me, the physical examination is very, very important. I need to feel the pulse, I need to record the pressure myself, and I need to examine all systems like cardiovascular, respiratory, abdomen, central nervous system. All these are not possible. Of course, there are telemedicine where there is a doctor sitting across there, the specialist is on this side, physician with the patient is on the other side, and he can examine and tell you what exactly the patient is having, but still it's not like you examining yourself and getting the data. So we are old 1970s and 80s batches, so we used to examining patients rather than ordering tests straight away. So that connect is not there. It's very difficult for us to accept telemedicine initially. But then the thing called COVID came 2 years back, and then all places were empty, including hospitals. So the only way we should connect to patients was through telemedicine. And of course, telepharmacy also. Patients are scared to come to the hospital, to the pharmacy, etc. So then the telepharmacy also started, where Patients started ordering medicines to the pharmacy, and the drugs were delivered to patients door through ambulances. So there was a lot of reluctance, as I told you initially, even for me. And then when the COVID came in, the teleconsults were actually became a necessity rather than an option. What I found was earlier patients from different, like for example, remote part of West Bengal or remote part of Bihar, all of them could have an access to consultation. It made life simpler for them, no need to travel all the way across to Bengaluru for opinion, and made life easier for a lot of people. The challenge is Wi-Fi network. So as you keep doing the consult, sometimes what happens is on the patient side, the thing gets cut off. And then it becomes very difficult for you to continue. Then you have to resort to the good old audio, make a telephone call for the patient and get the history and then give advice over the phone. So unless the Wi-Fi is uniform throughout, and sometimes there is a problem in the hospital also when some Wi-Fi connection to some rooms don't happen, then the telemedicine becomes very, very difficult to do. And government has brought in during this COVID thing both regulations for telemedicine, how far the prescriptions have to be made. All of them are very, very clear in the government regulations. So it's good that in a way, one of the advantages of COVID was telemedicine really boomed and some regulations were brought in for telemedicine from the government point of view. So coming to the electronic records, a lot of hospitals have gone completely electronic, OP and IP. We have started as the last 1.5 years for outpatients. And inpatient by April, we are planning to make the records completely electronic. The advantages of that are that all my patients, for example, a transplant patient who was transplanted in 2002, the 20 years of data is still coming to me for follow-up. The 20 years of data files are so thick, so it's very, very difficult to browse through the whole thing, number one. Number two, storage in the MRD. Because a major problem, you have thick files like that, and you have to find a place for storage of these files. All these have been made much simpler now with electronic files, and they just have to store it in the cloud now. There's no need for us to maintain all the records in the big room, MRD room, and then we'll have to keep it in a lock and key, all the security aspect of all these things were a problem. Now with this stage, what happens is that the OPD files are much more simpler to maintain. And for example, patient comes to me in nephrology and then he has to go to the next room to the urologist or andrologist for consultation. Then it becomes very easy. Click of a button is able to see. You need not keep transferring the files from one room to another, one room to another. All of them are visible for all of them on their desktop. So it made life much more simpler for the doctors and for the patients as well. We are trying to implement it in the inpatient. A lot of challenges in the inpatient. The OPD patient comes to me and then it's very easy. It's just one point. I have to examine the patient, put my notes and put my orders and write a prescription. That's the end of it. In IV, there are a lot of dynamics involved. The inpatient, we see the patient, write the orders. Then the drug administration nurses have to write their notes. They have to, once I write, let's say, for example, tablet paracetamol at 4 p.m. Now, we write the order for 4 p.m. paracetamol. The sister has to document telling that 4 p.m. paracetamol has been given. So it's a lot of dynamic. Physiotherapist comes and sees the patient. Dietitian comes and sees the patient. Let us say cardiologist comes and sees the patient. There's a lot of dynamics involved in patient. It's not that easy to just make it electronic and go electronic straight away. So we have to add a lot of dynamics to it and stat order. Sometimes they come and say, okay, patient is looking right. Let me give him 500 ml of IV fluid. So I write a stat order. So we have to make provision for writing stat orders apart from regular drug orders. So there's a lot of challenges involved in IP. We are slowly getting, and each hospital has to customize it to their case sheet. Now you can't have a general format and say, the same as for cardiology, same for nephrology, same for neurology, you cannot have it. It has to be customized for individual hospitals and the department. This is just how we have devised our OPD file. And you can see that see how the notes here. On top we have the diagnosis, we have the history, and we have the investigation done in our hospital, investigation is done outside also. got nursing notes. That is, as soon as the patient comes in, the nurse records blood pressure, height, etc. So those things are there in the separate. So we have to give provision for that for the nurses to enter those records separately. And of course, these are accessible to us. The doctor's notes may not be accessible to the nurse, but nurse's notes will be accessible to the doctors. So I mean, anyone can't go and keep changing there. Suppose I write something, someone can't just come in and overwrite my notes and write something else. So you have to give access only to certain people for certain things. So all these things have to be taken care of in the device in the electronic record. There's a place for prescription as well. We have gone digital long back in X-rays for nearly 10 years. So there's no more X-rays given in hand to the patients in the hospital. Everything is in HPACs and digitized. So once the X-ray is taken, it's loaded into the system. And advantage is that you do not carry the X-ray from one room to other. All doctors in the thing can view the X-ray at one particular portal. If they go and log in and put in the patient's PRN number, they will be able to see the X-ray in all the rooms wherever you are. The system is there in the hospital. The other thing is, I want an opinion from a cardiologist or anyone else. It's easily transmissible by WhatsApp to them. So they just see before they come in itself, they know what the X-ray of the patient is looking like. Suppose it's an abdominal pain, you're taking the X-ray abdomen to the patient. The surgeon has to see. Even when the surgeon is traveling in the car, the driver on, of course, he can view the images and come to the hospital and be ready to see if he really knows what is happening to the patient before he comes in. All these are really advantages of these days. A place for the patient where you get the clarity of the X-ray as good as having an X-ray film in hand. Nearly about 18 years back, we switched to summary dictation, dictaphone, which made life easy for everyone. So earlier we used to have a dictaphone and dictate. Now it's incorporated into all our phones. I just have to dial a number and start dictating. It goes to the section where they have to type the summary. So none of the summaries are handwritten. You know, doctors' handwriting is horrible, except very few. So you can't read anything. So I write a summary. Earlier days, you used to see summaries from everywhere. You used to spend half an hour trying to decipher what is written in the summary. Now life is simpler. We just dictate it over the phone, and they make the summary or letter, whatever, and then put it in your common folder. So I just have to access it from my desktop, correct the summary and put it back into the folder so that the printout is taken. If it gets over in half an hour, I just dictate and then the correction comes within 15 minutes to me, and then I make the corrections and the final result is taken. Printout is taken. Life much more simpler now with a lot of insurance. The summary takes a long time, the insurance process takes a long time. Life is made simpler with the sort of dictaphones where you can make the summary fast. I'd like to spend some time here on patient safety. We are one of the very few hospitals in the country where the entire hospital is connected with Massimo safety device. Massimo safety device Massimo is a US company. It's coming with the patient device where it's a simple thing. You just put the probe onto the patient attached to the device. To the patient's finger, you get it's like a pulse oximeter. You get the pulse oximeter and pulse rate. And if you are in the OT or if you are in the ICU, higher end model of the machines are available where ECG as well as the carbon dioxide, all those things in the OT parameters will come up, whatever is required for them. So what happens is that this is Wi-Fi connected, it's connected entirely through the entire hospital. So every patient room and every patient bed, whether in the ICU or on dialysis or in the OT, connected to this. Let us say first floor patients are there. Every room of every bed of the patient has this device, small monitor there. Yeah, this is the Massimo monitor. This is the one, this is the complex one which we use in the ICU. Whereas the ones in the ward will be almost smaller than this. So what happens is that the Massimo device is connected to the patient. It starts showing up on the patient room monitor. These are connected centrally to the nursing station. So the nursing station has a bigger monitor where you see that, let us say there are 10 patients in that floor. All the parameters of the patient comes in a small box there, room number 101, 102, 103, 104. So on the nursing desk, the nurse can see all the vital parameters of the patient in one place. So what has happened? We have what's called new scoring, modified early on score. Where let us say new score 1 will be patients at low risk. New score 4 or 5 is patients at higher risk for developing complications. So one of the things are all this pulse rate, oxygen saturation, blood pressure, all these things come into the warning score. So sitting at the desk of the nursing table, they can know which patient is going down. Suppose saturation is 95% becomes 89. So they can go pay more attention to the patient. Someone who is to be shifted to the ICU can be shifted much faster. Some action to be taken can be taken much faster with this Massimo device. So Massimo device is connected. And to add to the safety features, what they have done is they are given 2 pages. One pager for the same floor, let us say nursing station is there and the nursing supervisor of that floor. Once the monitor starts beeping either for a varying heart rate or varying oxygen saturation, what happens is that within 30 or 45 seconds, the beep goes to the first pager to the nursing in charge of the floor telling that action has not been taken. Within 1.5 minutes, the action is not taken. There's a second pager which is kept in the ICU with the doctor or the nurse in charge. The pager goes telling that from the first floor, so and so room, oxygen saturation is dropping. The patient meaning that means they have not attended to the patient. So there's multiple safety. One is it gives a beep in the floor, it goes to the nursing supervisor in that floor. And second one, it goes to the nursing person or the doctor in the ICU also. So that if one fellow sleeps off, the other fellow will be awake and make sure that they call the first floor and find out why the action has not been taken and the beep is going on. Of course, sometimes patient removes it, goes to the toilet, it keeps beeping. So all these things have to be taken care of. So the nurses are supposed to go and check why it is beeping. And if really patient is gone to the toilet, they have to go and mute it at the patient station. They can't mute it centrally because once it's muted, you will not know what's happening. So they've given provision for them, the privilege for them to only mute it at the patient's. When one patient comes back to the toilet or after eating, you have to switch it on. So this device has really done wonders in a lot of hospitals because a lot of early warning scores have been picked up and patients' lives have been saved. And early resuscitation can be started with this device. Not with this device, with the use of this device. And CCTV camera. This we have started about 10 years back. Most of the places CCTV cameras installed more for monitoring theft and who came in, who went out, etc. In our hospital, we use CCTV camera predominantly for patient safety measure. That is hand hygiene. Ours is one hospital where the doctor's hand hygiene is 100% in most of the areas in the hospital, which is a record. Doctors are the worst people who don't wash their hands properly. In fact, nurse follows orders, technician follows orders, staff follows. Doctor thinks it's be all and end all. So and people are scared to tell the doctor go and wash your hands. So hand hygiene monitoring, we started nearly 10 years back with the CCTV camera. And if you don't wash your hand and enter the ICU, your photograph will be done next day in the morning. The infection control nurse will monitor all this in CCTV camera and take a picture and say, Dr. Dilip, missed hand wash while entering ICU. It will be throughout the hospital. The image will go for everyone in the hospital to see. Same way for everyone. Even before this, our doctor's complaints was very good because we have built it into the culture. Very difficult to build the thing into the culture. So once you have built it into the culture that hand hygiene is important, then everyone follows. Our nurses is around 90%, technicians is around 85 to 90%, housekeeping is around 70 to 80%. So we not only look at doctors and staff, you can get infected from a housekeeping person who shifts you from the bed, from the ICU bed onto the stretcher, then onto a ward or for X-ray. So even the housekeeping, IMS, whoever it is has to wash their hands before touching the patient, wash the hands after touching the patient. In dialysis, for one dialysis session, about 80 times the technician has to do hand wash because patient mission. touch the, before touching the patient, wash, then machine alarm will come. They can't go and touch the machine straight away. They have to wash the hand and touch the machine. All these things are monitored completely directly onto CCTV camera. So I am happy to say that our hospital infection rates are very, very low. Medical people will know what's called MRSA, resistant staphylococcus is one of the dangerous bugs, as well as what we call belly bug. What's called Klebsiella, which is multi-drug resistant. There's no drug in the world which will act on it except one or two. So most of the super specialty hospitals have a MRSA rates of 40 to 50%. And most of the other things are almost coming to 20-30% now. With all our hand hygiene and our antibiotic protocol, I'm happy to say that our MRSA rates are only 5% after so many years in the hospital. And our other, the Delhi bug, now from a lot of patients coming from other hospitals, Delhi bug is slowly coming up. But our Delhi bugs are extremely low, less than 1% a year back. Now we have patients from a lot of other hospitals coming in, already treated with antibiotics and having a lot of foreign bodies inside, stains, etc. So rates are going up now, but with strict hand hygiene measures and antibiotic protocol, you can control bug resistance as well as infection rates. Here, as I told you, on a daily basis, we get the information from all quarters. In fact, from dialysis, from OT, from wards. What we do is, this is the pattern. We write the location, time, area, doctors, nurses, technicians, housekeeping, etc. Number of opportunities of hand wash. Suppose I go and see a patient, the opportunity of hand wash is 4 times. How many times I have done it? Is it 3 out of 4 or 4 out of 4? So the percentage is calculated based on not the number of patients you see, number of opportunities per patient. So I may first wash my hand and then put the state on the patient. Then again I come back and then I know the pulse of the patient. So the opportunities are 2, not 1. First washing is 1, putting the step. After I put the step and come back, I have to wash my hands and again feel his pulse. So the opportunities are 2. So all these things are looked into in detail. So how many opportunities, how many missed, what the percentage. And then as I told you, photos flash throughout the hospital. You know who are all the fellows and you know who all have to be trained again. Dialysis, new technicians come in, we train them. They don't imbibe the culture. So we know who are all going wrong. It's not a punitive thing, but we are built in that culture. Earlier, we used to write incident reports. Even now, I am one of the strictest person writing incident reports for everything in the hospital. So they're scared when I come around. They don't know what I will catch out them in part. But the point is, the incident reports earlier we used to say staff nurse 1. She used to be thinking that punitive action will be taken against her. Oh, I have not administered drug properly. Now what we have done is we have removed all the names in the incident report. It just says SN001. No one will know who it is. So we are concentrating on the process, not the person. So today this nurse, tomorrow some other nurse is going to do the same mistake. So how do you correct the process rather than the person? That is the idea, and then this culture is built in well, and now it's taken up very, very well in the hospital. Another important thing is we have incorporated critical alert system. That is the lab. We have primed the lab already. We have fed into the machine. What are the critical alerts for various parameters? Say, for example, blood sugar. You would have put in 300 as the higher limit and say 60 as the lower limit. Let us say serum creatinine, which is our field in nephrology. You would have put in say 7 or something as the higher limit. And for each parameter, hemoglobin, you would have put in 16 as the higher limit and let us say 8 as the lower limit. So from the machine, anytime these reports are generated from the machine, automatically the abnormal parameters will go as a message to all the doctors, the consultants. For example, and the location also. We have 3 units in Bangalore. So it tells you NU South, PRN number 111222, hemoglobin 5. So all the doctors will get. So even as outpatient, if you come and go, or inpatient, you are there. At any point of time, the morning or night, I know. Even the night, middle of the night, someone 12 o'clock, some patient comes in, parameters is abnormal. I check the report and then call back to find out if I am on call, whether action has been taken, the duty doctors are sleeping or are acting. So such a device where the abnormal lab parameter message goes to the doctor with all these reports, and then there's a register in the lab. The lab, apart from sending messages, they'll also call the doctor and write down that which doctor has been informed about the abnormal report. The doctor said there is an Excel sheet where they have to maintain, let us say, someone's sugar is 40, this is an outpatient, is someone given blood and gone is 40. Now they are supposed to call the consultant on call, find out what is the problem, call the patient to find out what is the problem, and then give the solution, what it is, and they have to document. The Excel sheet, we are monitoring this like a hawk every week. The Excel sheets, the number of critical alerts that have come are matching with the number of actions taken in the Excel sheet. Every week we match and see whether it is, sometimes the critical alerts will be 10, whereas the entry by doctors will be 7 only. Then we find out who is not entering, why we are not entering, whether action taken and not entered or action not taken and not entered. All these things are very, very important. It's a big headache for us, but the patient's point of view is absolutely safe. Technology has made it easier for us to monitor all these things. So we have incorporated simple things. It's not a great thing like AI and all those things, but simple things made a major difference in patient care and patient safety. Then our hemodialysis machine. In fact, our Fresenius hemodialysis machine has what's called a TDMS, therapy data monitoring system, where the machines are again connected to a thing. So with TDMS, what happens is that it's connected well, and sitting at home from my laptop or my phone, I know all the parameters of 11 patients who are undergoing dialysis. I can give them instructions as to what is to be changed during dialysis session. Same way, we've got an automated petroleum dialysis machine where we have interactive devices. Patient is doing dialysis at home. These parameters come straight to me, to my phone or to my laptop, and I know what exactly is going wrong or what is going right. Of course, in our IT, we have one of the very good technical details I do not know, unfortunately, but we have one of the very good IT systems where the backups are very good. We store it in the cloud, and we have 3 units in Bangalore and 4th one in Ambur. So the backup is done between units. So the south unit is backed up in west unit is backed up in south, and Shimoga is backed up in west and south. So that any loss of data from one place can be retrieved. HR has become totally paperless, and all the training records, all the vaccinations of staff, which is very important. That's also a safety point of view from the workers also. Not only from patient safety, the health worker safety also has to be looked into. So all the data regarding the safety of everyone is kept in the HR file of every person, which is become paperless now. And all our finances also. What is this one, that is the salary, what is the deduction, everything can be viewed in one thing. And we document a lot of things. Memos being served to people for wrongdoings, and of course, positives and negatives are all documented in each and every one individual file from hospital to the top consultant. So anything, suppose there's been a complaint against the consultant regarding anything, all those things will go into that file. I mean, everything is documented, not a single thing is left undocumented. Disadvantage of digital legal. A lot of consent forms are not still very clear whether we have to take the patient signature or digital signature is okay. A lot of still we are taking consent forms with the paper and then we are loading it into the system. Of course, privacy, we all know, cyber security is a problem we had with names now. So struggling a lot. There's a big problem with digitalization. Once I started seeing patients, if there's a problem with the internet and it's down, everything from the front office to the OT, there's a stop to everything because you can't register, you can't generate reports in the lab, you can't enter records in the thing. So still some amount of manual thing has to be a backup for this. Access to internet. Of course, elderly people, very difficult for them to say, go to this app, go to that app, they will not be able to do it as well as an individual. And patient connect. Now patients are starting asking, doctor, I'm talking to you, you're sitting and typing. So they want you to they're listening to them. So one period after I tell them, boss, I'm typing only what you are telling. I'm not typing anything else. So the connect is not there because there's more entering all the data. This is our latest CMS license system of Robo. Robo is fast. I'm not a surgeon, but it's all math derived from net and from my colleagues. So almost all these fields of robotic surgeries have been introduced. Now, general urology, oncology, we have a lot of surgeries being done in urology now. Effective removal of kidney, bladder repair, a lot of children undergoing surgeries where the ureter is to be connected to the bladder. These surgeries, a lot of prostatectomies, all these things are now being done using robo. The advantages are shorter hospitalization, reduced pain and discomfort, skill. In fact, it can go through very difficult areas and suture where you cannot do it manually. Where you have to struggle to do manually, it has a nice maneuverability of going in and taking sutures, bites, everything. Smaller incisions resulting in lesser infection, lesser scars in the body, reduce blood loss and transfusion, minimal scarring. Point is, unfortunately, there was a report from UK where a half-trained fellow was dependent on 2 more people for handling this. Those 2 people who were supposed to be helping him went out for coffee. The patient died on the table because the robot went and cut the whole thing. So, and that was debarred from practice for about 10 years, something like that. But of course, now he's back, but not into that, but in a different field. Unless there's also a human element, unless you know how to do it and you're skilled, trained, and then apply your mind. Advantage here is robot, you can sit in the room and do. There's no need to stand and do prolonged surgery. You can sit and maneuver it very, very well, very, very comfortable to do. Disadvantage here is costly. So approximately around 2.5 times more costly than regular. So suppose surgery costs 1 lakh. Laparoscopy costs 1.5 lakhs. Robotic surgery costs 2.5 lakhs because the investment in robots is very heavy. Goes in crores. So the cost has to be recuperated, and so all the surgeries are very expensive. As I told you, complication surgery. There is it's a master slave. That's what the master orders it to do. The master is sleeping and the slave does what he wants. It occupies a lot of space. The earlier days, when the hemodialysis started, when dialysis was there, one machine used to be the size of the room. Now it's all very compact and one slim machine which is there. So hopefully, robotics will become like that over a period of time. Other thing people are scared is unemployment. Probably they replace a lot of doctors. And for example, MRD. Now most of the records are electronic, and if you have a robot there sitting and filing everything, there is no need for MRD. Similar way in pharmacy also, a lot of robots are distributing drugs, storing, inventory, everything is done by a robot. So whether it will lead to large scale unemployment over a period of time is a cause of concern. Thank you very much for your patience. Happy to answer any questions if you have.
Thank you, sir.